All right. A nurse is assessing a client in the immediate postpartum period. Which sign would indicate uterine atony? Okay. So uterine atony, what is uterine atony? Does anybody know?
Was I supposed to
The
push one of
uterus
these
don't
colors?
contract.
Yeah.
Oh God, this is awful. Okay,
You're
I'm
gonna
gonna
be
catch up. I'm gonna
you're gonna
figure it
figure
out.
it out. You're gonna figure it out. Okay, what is, I'm sorry, I missed the answer. What is uterine atony? Somebody said something and I missed what they said.
It's when the uterus doesn't contract.
That's right. That's what's happening. So atony is the absence of tone or atonic. When the baby comes out, the uterus needs to contract and squeeze. Okay. If you think about the placenta is about the size of a dinner plate, and it has been taking up residence on this whole side of the uterus, wherever it's attached. And that whole area has these huge vessels that have been feeding that placenta. So all the things we've talked about with placental perfusion and all of that, that's what's happening is these vessels have grown really big to give all this blood flow to this placenta. So when this placenta comes out, if this does not contract and squeeze, this whole area has these huge vessels now that can just hose blood. All right. So what needs to happen is the muscle of the uterus needs to contract and squeeze and compress those vessels so they don't bleed. All right. So in the immediate postpartum period, if we have uterine atony, if we feel for the uterus and it feels squishy or spongy, it's not contracting well. And so that would be uterine atony. That's really bad because that's going to be our number one cause of hemorrhage in the first 24 hours. A postpartum client is diagnosed with cystitis. The nurse should plan for what priority action for this client? So Shani, like now you can see the different shapes and the colors. So in the screen, you can see the answers like red is provide sits baths and so on. And then on your game, you click which one you think is right. Okay. So what's this going on with cystitis?
It's a bladder infection.
Okay. Good. And so we have a bladder infection. And so if we have a bladder infection, then encouraging fluid is going to help her flush that through. Okay. So the other choices for this don't really fit for bladder, but fluid intake is going to help flush it out. She's probably also going to be on antibiotics. Which assessment finding would best indicate the presence of a hematoma with a client with an epidural? Okay, so with a hematoma for a patient who's on labor and delivery, on postpartum, where do you think the hematoma would probably be?
Are we talking about if they gave the epidural in the spine?
That's actually a good point, right? That the idea of the question is that the hematoma is probably like in her vagina or in her vulva. But if you're thinking, well, she had an epidural, so maybe the hematoma is where they place the epidural, then that's also a possibility. I would say that it's not probable that she has a hematoma there, but I can see that thought process for sure. If we have a hematoma, what's happening with a hematoma? What's a hematoma actually?
Like a localized,
Bruising,
yeah, like a
blood collection.
Okay, a collection of blood. And Glenn, what are you saying? Localized what?
like a localized collection of blood, like a local.
Yeah, so it's kind of in one spot and it's blood. And so this collection of blood, um, the idea for the question, when I chose it, is that it's vaginal or it's in the vulva because that's typically where we can see hematomas in labor and delivery. But even if we had it in where they put the epidural in the back for some reason, it's a collection of blood. So we're losing volume from mom into this tissue. And so seeing vital sign changes would still be something we would see. The idea of the question is that if she had a hematoma in her vagina or in her vulva, we would oftentimes see a woman who's complaining of intense pain and that tearing sensation as it's filling with blood because it's very painful at that site. But if she had an epidural, she might still be numb down there. Okay, so then the first thing we might see is not pain, but vital sign changes. So what kind of vital sign changes would we see if somebody's becoming hypovolemic because their blood volume is going into the tissue?
Decreased blood pressure.
Decreased blood pressure. And even before that, there's another vital sign change that happens before the blood pressure goes down.
Would it be tachycardia?
Yeah, good. So tachycardia is usually the first thing we see. All right. If she's becoming hypovolemic because she's losing blood volume, whether it's a hematoma or a postpartum hemorrhage from like uterine atony or whatever, tachycardia is usually what we see first. Then, as this progresses and as we're continuing to lose more and more volume, then the blood pressure starts to go down and we can start seeing hypotension as well. Okay. When assessing for signs and symptoms of a superficial venous thrombosis, which sign would the nurse note if present? Okay. So with a superficial venous thrombosis, this is superficial. So it's not going to be quite the same as if you have a deep vein thrombosis because the superficial one you can actually palpate. And it palpates as an enlarged hardened vein. It's not as concerning as the DVT, not as probable to cause a PE if it was dislodged. So, so we can usually palpate it. If we had signs of a DVT, we would see like warmth on the calf, redness, and maybe an inability to palpate a pulse. But so when we're thinking about venous thrombosis, whether superficial or deep vein thrombosis, these are because the pregnant ladies are hypercoagulable. What do you think that we do as nurses to try to minimize venous thrombosis in the legs, whether it's superficial or deep DVTs, for our pregnant patients and our postpartum patients?
Like apply stockings.
We could definitely apply stockings. What else?
Ambulate.
Yeah, walking.
Ambulating is a big one. So especially like our patients, our C-section patients, we're getting them up and getting them walking pretty soon after they deliver. There's also something called SCDs or synchronized compression devices. So if your patient is going to be in bed for a while, we also can use those as well. So we'll put them on for our C-section patients until they are up and walking. Also, if you have a patient that ends up on bed rest for a prolonged period of time, like if they are preeclamptic on magnesium sulfate and they are in bed and stuff like that, we'll also use SCDs for them as well. But compression stockings is a good other idea to use. But ambulating is going to be the big thing, getting them up and walking if we can. Which observation, if noted in the mother, indicates a need for further assessment related to postpartum depression? Oh, so Shani, are you still on your phone also? So you should see the question on Zoom with me, and then you should see the game to answer the questions on your laptop where you put in the code. Do you see, like, if you look at where you're on Zoom with me, where you have I have my screen shared, do you see the questions there? Can you, on Zoom on your phone, can you swipe? Because you might just be seeing all the participants instead of seeing the shared screen. Did that work? You could also switch and join the Zoom from your computer and then get into the game from your phone. That's what I see, the shared screen participants. I think if you swipe, I think that's how you can change your view, is swiping your screen. So instead of seeing the shared screen of participants, you see my screen. Okay. Good. Are you just saying that so that we keep going? I hope you can see it. Okay. So let's talk about this question. You guys all did really well with it. Okay. So when we say what would require further assessment related to postpartum depression, so complaining of tiredness and fatigue. How can I differentiate between postpartum depression and baby blues for a mom who's feeling tired and fatigued?
Postpartum depression lasts longer and it's usually, so the duration is long and they sometimes don't have baby bonding.
Okay, good. Yep. So I think it's not so much that this mom is feeling tired and fatigued because all new moms do, but it's the fact that she's consistently complaining about it that is concerning. And then if we're seeing these symptoms that are worsening, lasting longer, like Shani said, or also if it's affecting her ability to bond with her baby, those are all concerning things. All of these other options for this question are all very appropriate things that we're not concerned about. So caring for her baby, interested in her surroundings, and looking forward to visits from the father are all good things, but the complaints are concerning. Which action should the nurse encourage the client to do to prevent thrombophlebitis after cesarean delivery? See, y'all better get this one right. I didn't realize I was giving away answers. What should we do? to prevent thrombophlebitis. We should ambulate. Good job. We get them up and moving really pretty soon after, within, I think that the recommendation is 6 to 8 hours, but we'll usually do closer to 6. The nurse knows the client has decreased urinary output, pallor, and tachycardia. What action should the nurse take? Okay, so urinary output decreased, pallor and tachycardia. We had already talked about how tachycardia is one of our first signs of hypovolemia. Okay, if she is pale, and especially if she has decreased urine output, because that means that she's probably lost a lot of volume if it's affecting how she's perfusing her kidneys. This is a bigger issue, so we're needing to assess, like, are we losing blood? Where are we losing blood from? And we should also loop the provider in. Okay, I don't disagree with fundal massage because that could be where we're losing our volume. And so that could be a place to assess, but oral fluid isn't really going to help with this situation. So I would look for, like, checker pads. Where's the blood going? Notify the provider, and then definitely assessing for uterine atony because that is the #1 cause. Monitoring a client in the 4th stage of labor, which may indicate the presence of a laceration in the birth canal. Okay, so if we're saturating a peri-pad in an hour, that's bad. What's happening? What's the 4th stage of labor?
Delivering the placenta.
It's actually going to be after the placenta. It's going to be those first 2 hours after the baby's born. The placental delivery is going to be in the 3rd stage. So we're in the 4th stage of labor. We're in the first 2 hours after the baby's born. And if we are saturating a peri-pad per hour, what would be the first thing to check? What would we
If
assess?
the uterus is firm or contracted.
Good. Let's check the fundus first, because like 70 to 80% of the time, if we're saturating a peri-pad, it's uterine atony. So what might your finding be that might indicate that it's not uterine atony and it's a laceration?
The
Like
fundus
that
is
it would
back.
bleeding.
We have the bleeding, but the fundus is firm. So if we notice the pad is saturated, we should check the fundus first. If we check the fundus and the fundus is firm, that is going to be an indicator that maybe it's a laceration that's bleeding. And what we'll probably see is a blood-soaked peri-pad, firm fundus, but still seeing this kind of constant little trickle of blood coming from the vagina. Can be an indication that we have an unrepaired laceration. And so even though the uterine atony is definitely significantly high for being our cause of hemorrhage, #2 is going to be unrepaired lacerations and hematomas. So we'd still see, we'd have a firm fundus. With a laceration, we have a firm fundus, we still have a bloody pad, and we have a constant trickle of bleeding. If it's a hematoma, we have a firm fundus, we don't have a bloody pad, but we have signs of hypovolemia, like the tachycardia, hypotension, the things like from that other question. So these are all different ways that we could be losing volume. Which finding, if noted during the first 24 hours after delivery, supports a diagnosis of postpartum endometritis? Okay, does anybody know what is going on with endometritis?
It's an infection of the lining of the uterus.
Good. Yep. And so abdominal tenderness is going to be a symptom because it's inside the uterus. Okay, chills could be a symptom. This temperature of 100.2. Let's talk about this for a second because this is a kind of an important thing to keep in mind. And that is the question says she's in the first 24 hours after delivery, which is a clue. But it's our kind of our temperature parameter for infection is going to be greater than 100.4. But this patient's in the first 24 hours after delivery, and so a temperature of 100.2, I'm not super worried about because in those first 24 hours after delivery, she can be dehydrated, have had a lot of fluid shifts happening with labor and delivery, and she can have a little bit of an increased temp. And so for that patient, I would hydrate her and see if we could get her temperature to kind of come down a little bit just because I think she's dry. But the abdominal tenderness and chills is going to be concerning for infection. What else if we had a patient with endometritis? So we just determined that the infection would be in the lining of the uterus. What other signs might we see?
Tachycardia.
Okay. Anything else? Maybe like a foul smell to her discharge. So lochia will be normal in the first 24 hours. We have lochia for lots of weeks after. In the first 3 days is lochia rubra. And lochia rubra is red and bloody. But it should kind of have just a normal fleshy smell to it. So if it has an odor to it, that can also be a sign of infection also. The nurse is caring for 4 one-day postpartum clients. Which client assessment requires the need for follow-up? I haven't played this game in a little while. I'm giving all the answers away, but I'm glad you guys were paying attention. If her lochia has got a foul-smelling odor, what could that be?
Endometritis.
Endometritis. I know as soon as I saw the answer, I was like, wow, there we are. But good job. That just brought it all together. A nurse is monitoring a postpartum client who's bleeding for signs of shock, which indicates an early sign of shock. Yep, it's going to be that heart rate going up. That's going to be the early sign. A nurse is caring for a client with subinvolution, which should recognize which condition is a cause of the diagnosis. Okay, so endometritis is a cause of subinvolution. What is subinvolution?
Is it where your uterus is not like moving down the way it should?
Mm-hmm. Yep, that's right. So uterine atony and subinvolution are similar, but they're not the same. So uterine atony is the uterus's failure to contract and stay contracted to control bleeding. Okay. Now, this is the biggest concern, as we said, in the first 24 hours. Subinvolution is the uterus's inability to return to its pre-pregnant state. So not only should it contract, but then it should be starting to go down. And it should go down, who knows how much it should go down per day.
Is it like 1 finger breadth or whatever? Okay.
Mm-hmm. Yeah. So one finger breadth, which is about a centimeter. So we measure it this way because we're palpating with our fingers. All right. So each day it should go down about 1 centimeter. And so it quickly goes back down into the point that you can't palpate it anymore because it lives down in the bony part of the pelvis. If it's not doing that, that's subinvolution. It may feel boggy on palpation and it may feel like it's kind of firm, but it's just not going down. And so usually if you have subinvolution, it's either going to be infection in the uterus, which endometritis is the main one, or the other thing that can cause subinvolution is retained placental fragments. So if there's little bits of the placenta that are still inside, it keeps the uterus from contracting down back to its pre-pregnant state. Retained placental fragments can also cause uterine atony in those first 24 hours and prevent the uterus from contracting well to control bleeding. All right, so either way, not good. Which statement made by a client would indicate a need for further instruction for prevention of mastitis? Okay, so this question says need for further instruction, which means which of these answers is false, right? If it says what needs further instructions, it's going to be an answer that isn't a true thing. So it is true that she should breastfeed every 2 to 3 hours. And it is true that showering before breastfeeding is something she could do because the warm water is going to help her milk let down, which is going to help the breast empty, but it's also going to help wash the nipples so that we are preventing like bacteria. All right. Now, washing though with soap and water is not indicated. And the reason for this is soap is very drying and can cause cracks, which can be a place for bacteria to get in. All right. So we don't want them to use soap. So showering and letting the warm water hit her breasts is fine. Using soap on her nipples isn't fine. Okay. And then changing breast pads frequently would be helpful for keeping her breasts clean as well. So the idea here is no soap. A postpartum woman with mastitis says that the left breast is too sore for her to breastfeed. The nurse should what? All right. So for if we have a patient with mastitis, breastfeeding is really painful. But we want her to still be emptying that breast. We don't want that to stay stagnant in there. So any of these answers, if this says involves not breastfeeding, it's not the right answer. If it says give the baby a bottle, it's not the right answer. Okay, so we got to look at what is going to help her still breastfeed her baby and keep that breast emptying and promote her healing and her breastfeeding. And so the best choice for that is blue, where she can breastfeed on the unaffected side and then gently pump the affected side. She could pump it. She could also latch the baby on that side as the second side when the baby's not as vigorous to feed. So that would be a choice also. But this pump on both sides and discard the milk, we don't need to discard the milk. It's totally safe for the baby to drink it. Bottle feed on a temporary basis isn't a good choice, and stopping breastfeeding from both breasts until the condition resolves isn't a best choice either. The nurse plans to use both hands to assess the fundus of a prima para in the immediate postpartum period in order to what? Okay, so let's think about this for a second. This is considering how to assess and massage the fundus. And so we need to support from below, and then we're going to assess from the top where the fundus is. Okay. We're supporting from below because that if we're pushing, especially like if she's bleeding and we're really having to do a lot of massaging on the fundus from the top, if we're putting a lot of pressure from the top, we can cause the uterus to sink down and to turn inside out and go down into vagina. If that happens, that's a huge hemorrhage possibility because uterus can't contract well like that. Plus, it's super painful for the mom. So we always need to support from the bottom side as we massage from the top. Okay, so preventing uterine inversion is the reason. As far as the size of the fundus, how do we determine the size of the uterus postpartum? Anybody know?
By massaging it.
Well, it's just going to be really by palpation, right? When we palpate it, we're going to see where we feel it in relation to mom's anatomy. Okay, where should the fundus be after delivery?
Near the umbilicus.
Yes. Okay. And so that's really how we're determining the size, is just kind of where we find the fundus in relation to the mom's anatomy, and we're using the umbilicus as our landmark. And then also correct then that we're looking at number of days postpartum and where are we in relation to that belly button and how far have we come down, because we should be coming down about a finger breadth or a centimeter per day, which is what we talked about with normal involution versus subinvolution before. Okay. The uterus is 1 centimeter below the umbilicus 3 weeks postpartum. Which pathophysiological cause could contribute to these findings? Okay, so this is everything we just were talking about. So let's think about what's happening for this patient. Her uterus is 1 centimeter below the umbilicus, 3 weeks postpartum. Where should her uterus be 3 weeks postpartum?
Like like by the pelvis.
Yeah, I shouldn't be able to palpate it 3 weeks postpartum. It should be in the pelvis. You're right. So if it's 1 centimeter below the umbilicus 3 weeks postpartum, what is that?
That is where we just talked about.
Subinvolution.
Good. That's subinvolution. And what are our main causes of subinvolution?
The leftover pieces of the placenta and endometriosis.
Yes. Good. Okay. Does it make sense?
Yes.
Good job. A new mother has saturated 2 pads in 30 minutes and has a boggy uterus. What action should the nurse implement first? Okay. We have a boggy uterus. So we walked in on our patient and she has saturated 2 pads in 30 minutes. Is that too much bleeding?
Yes.
Mm-hmm. So the first thing to check when we have a lot of bleeding is the fundus.
Fun.
First thing to check. Check the uterus first, because number one cause of bleeding is going to be acne. So it says that she has a boggy uterus, which means they checked the fundus and she has acne because it's not firm, it's boggy, and boggy is like squishy, not contracting well. So if we have a boggy uterus and bleeding, the first thing to do is massage the fundus. Try to make that muscle squeeze. Okay? There's other things to do to try to help facilitate that uterine contraction. And so massage is number one. And then what else should we do if she has a boggy fundus and is bleeding besides massaging the fundus?
Look at the bladder.
Okay, let's consider the bladder. So if she's saturating pads, I'm not getting her up to the bathroom. I'll probably put in a Foley. If she has a boggy fundus, but I just found it on assessment, she's not currently bleeding right now, then I could have her void. So you'll use your nursing judgment as far as what you're going to do about emptying the bladder, but we do need to empty it. If the bladder is full, it puts pressure on the uterus, and the uterus doesn't think it needs to contract as much. Okay, so bladder is the next thing to do. What else could we do to help with a boggy uterus besides massage and empty her bladder?
I mean, you would be monitoring her vitals too, but
Mm-hmm. Is there anything else we could do to help encourage the uterus to contract?
There's a medication.
The
Oxytocin.
I can't get
oxytocin,
the
but we
name out
have
right now.
used it.
Oxytocin was one of them. I heard you guys say that. There's actually 4 medicines we can use for this.
Pitocin.
So Pitocin and oxytocin, we kind of use those words interchangeably.
Is it
What
the
else?
Metagen? Never mind.
No, you're right. Okay, Methergen, oxytocin, Methergen. There's 2 more.
Is tetrabulan one of them? Can't pronounce it, tetrabulan or something like that.
Terbutaline is a medicine that helps the uterus relax. So we do use it like terbutaline we will use if we'll use it like with late decelerations in labor to help if she's contracting too frequently. We also are going to use it next week when we talk about preterm labor because that's one that is tocolytic that makes uterus relax. As far as ones that make it contract, Pitocin or oxytocin is one, Methergen is one. There's one that starts with an H. Anybody know that one? Hemabate. And then Cytotec, or also called misoprostol. So it's going to be important to know the 4 medicines that make the uterus contract and the 4 medicines that make the uterus relax. So for our postpartum patient, we want to consider medicines that can help the uterus contract because she has a boggy uterus. So we're going to massage her fundus first. We're going to manage her bladder, and we're going to think about those 4 medications: oxytocin, Cytotec or misoprostol, Humabate, and Methergin. As far as those that picked green, inspecting her perineum for lacerations, this is a good thing to do if the pad was saturated and the fundus was firm. Since she has a boggy uterus, we're really mostly concerned about acne for her. The uterine fundus right after delivery of the placenta is palpable at we should be about at the belly button. That's our landmark for where we expect to find it. Midway between the umbilicus and the symphysis pubis, typically it's not going to be that low because that's going to be, if you think about the anatomy and where the belly button is, that's going to be pretty far down. That's probably where we would expect to find the fundus many days after delivery. If we think about going down about a finger width per day, probably by 4 or 5 days after delivery. Also, guys, it should be midline. It should be in the middle of her belly, not off to the left or the right. After delivery, the nurse notes excessive vaginal bleeding after IV Pitocin is infused. What's most important to tell the doctor? Good. Okay, because this is going to be a sign that we've really lost a lot of volume. This is an important bit of information if she's hypotensive. Which statement by the mother indicates she understands her discharge teaching about the rubella vaccine? Okay, so the rubella vaccine, we don't want her to get pregnant after she gets it for 1 month. Anybody know why?
Could it cause deformities or something like that? Or health problems for the fetus?
We're gonna give it postpartum, and we don't want her to get pregnant for a month after because it can affect that next fetus. Yeah. So, it's a live virus. Okay, so it's the concern is if she gets pregnant too soon after she gets the rubella vaccine, that it could have an effect on that baby. All right. The nurse notices a steady trickle of blood from the vagina. The fundus is firm. What might be the cause? This is, if we have a firm fundus and a steady trickle of blood, we're concerned about laceration. If we have a firm fundus and no blood on the pad, or normal loci on the pad, but we have those vital sign changes and those other signs of hypovolemia, that might be a hematoma. Okay, so if our patient was hypovolemic, what signs might we see besides the vital sign changes we talked about?
Skin tinting,
Okay. But think about hypovolemia related to blood loss.
pallor,
Mm-hmm.
So are you saying like the patient may be in shock?
Yeah. What are
Like,
our symptoms of hypovolemic shock?
Is that like the help or am I mixing it up?
Oh, help. Help is going to be a separate thing that related to preeclampsia.
Like it,
So this is just still thinking about hemorrhage and blood loss.
like her skin would be like cold.
Mm-hmm. Cool, clammy skin, pallor. We can see the vital sign changes we talked about, so tachycardia, hypotension, decreased urine output. So if we have
no, I'm
those
saying she might
signs,
be dehydrated. Oh, never mind,
no,
sorry.
no, go
I
ahead.
was
What
just
do
gonna
you?
say she might be dehydrated.
So if she's dehydrated, some of those things we'll still see. Like I don't know who iPhone is, but that said the like tenting and things like that too. But and we also talked about dehydration related to just the normal birth process and how we can even see a little bit of an increased temp and those things. If our patient though is like having has pallor and cool clammy skin and stuff like that, then we might still want to look closer at if she's losing blood somewhere. So if her fundus is firm and her pad it isn't bloody, but she has some of those other signs, we might look for a hematoma. If she is got a blood-soaked pad and her fundus is firm, I'll look for laceration. If she has a blood-soaked pad, and I would first check her fundus, and if it's not firm, then I'm thinking acne. So there's a few different things that can be going on with her. The hematoma is usually easy to find because that she's also having vaginal pain and pressure. So for this girl though, she has that steady trickle of blood happening, so that's probably a laceration because her fundus is firm. Which of the following complications is most likely responsible for a delayed postpartum hemorrhage? Good. Yep, that's it. Subinvolution. Which of the following circumstances is most likely to cause uterine atony and lead to postpartum hemorrhage? Okay, so uterine atony, full bladder is a big culprit for this. Okay, endometritis is a big culprit for subinvolution. But in this first 24 hours, the uterus needing to contract to control bleeding, if the bladder's full and putting pressure on the uterus, it doesn't contract as well.
So you would correlate endometriosis with sub whatever. Okay.
Yep. Correlate endometritis with subinvolution. Uterine atony is going to be things like the full bladder. The nurse is documenting assessment findings on a client 14 days postpartum, which indicates a normal involution process. Okay. 14 days postpartum. Should we be able to it asks what normal involution is. So what's involution again?
Where the uterus shrinks back to pre-pregnancy.
Yep. And 14 days, should I be able to palpate it?
No.
No.
Nope. Okay. Now let's look at the, excuse me, let's look at the yellow option because somebody chose yellow. Moderate bright red lochial flow. So today we talked a lot about uterine atony. We've talked about lacerations. We talked about involution versus subinvolution. So let's talk a little bit more about lochia. Okay. So lochia is the discharge that happens after the baby's born. And it follows a process. So does anybody know like what happens with lochia, like what we have and when it happens?
Can you repeat the question, please?
Yeah. So with lochia, it's going to kind of gradually change. So it starts out a certain way and then it gradually changes. So I was wondering if we could talk about how that changes. So what does it look like initially? What does it change to? How long does it take?
It's first lochia rubra,
Mhm.
and that should be like a brighter red.
Mhm.
And I think that lasts for 3 days.
Good. Yep. And then what
Um,
happens?
it changes to a lighter like pink.
Mhm.
I can't remember what else.
I think it gets
Then I think,
thinner as time
yeah,
goes on too, doesn't it? Like it goes
yeah.
from like thick to getting thinner,
Yep. Yep.
and then it'll
So
eventually get white and kind of yellow, like back to normal or like a normal appearance.
yeah. Right, that's good. So in the first few days, it's the red kind of bloody discharge, and we call that rubra. And then the pink one, when it goes kind of pinkish, and sometimes it can also be a little brownish, like old blood is mixed in there too. So this pinkish and thinner is, what is that one called? Stenicia has it in the chat. It's
Like
serosa.
lochia, so yeah, serosia.
Good. Lochia cirrhosis next. And so this is going to be from about day 4 to about day 10. And then is when Shani talked about the whitish, yellowish, and that is, does anybody know what that one's called?
Alba.
Good. That one's alba. So for this patient in this question now, it says 14 days postpartum. What kind of lochia would we expect to find for her?
The last one.
Good. Lochia alba. All right. At 14 days, she should have the whitish, yellowish, not bloody discharge anymore. Which instructions in the discharge teaching plan assist the patient in recognizing early signs of complications? Okay. Increase in the amount of lochia or return to bright red. So guys, it should go what we said, rubra serosa alba. If it goes rubra serosa back to rubra, back to red, that's not good. Okay, and that actually can also be a sign of subinvolution. All right, so if she has lochia that goes back to bright red bleeding, she definitely should report that. Okay. 2 hours post-delivery, the fundus is 3 centimeters above the umbilicus and to the right. What can bladder distension cause postpartum? Okay. Let's look at what the question says. The fundus is 3 centimeters above the umbilicus and to the right. Is that where it should be?
No.
Where should it
No. In the middle.
Midline.
be? Midline. And should it be about at the umbilicus? The answer is yes. Should be so 2 hours post delivery, it should be at about the belly button and it should be in the middle. If it is up and to the right, that's a huge sign of a full bladder. And the bladder distension putting pressure on the uterus is really going to affect the uterus's ability to contract, can cause uterine atony, and can lead to excessive uterine bleeding. The nurse lists fever, foul-smelling discharge, and subinvolution of the uterus as signs of what condition? Yep, good job. The nurse assesses the postpartum vaginal discharge of 4 clients, which would require notification to the MD. Okay, so remember that we have lochia rubra first, and how long does it last?
1 to 3 days.
Okay, and the next is serosa. It's pink or brownish, and it lasts until about when?
4 to 10.
Okay, it's going to go from 4 to 10 days. So if we're 5 days after delivery, what should it look like?
Light pink.
Mm-hmm.
Serosa.
Yep. So if we have bright red discharge 5 days after delivery, then that's the one that's abnormal. This dark red discharge on the 2nd day postpartum is okay. So rubra can be bright or dark red. Okay. And so this one's okay. This one's not. The blue one is normal. So that one's day 5 with pink or brownish discharge. That's the serosa. Colorless or creamy discharge 2 weeks after delivery is what?
The last one, the A word.
The A word, alba. A delivered client has a temp of 101.4. The uterus is tender, unusually large, and not descending. What should we assess next? Okay, let's think about this one for a second. She has an unusually large uterus, so that could be something that we would think about. But for acne, but what else does she have going on?
I
A
was
T
thinking she
Go ahead. What's going on with her? This one's harder because it doesn't tell you, it says she's delivered, but it doesn't tell you how long ago she delivered. But let's think about what we know and
So
figure her
the
out.
uterus isn't descending, which means that's subinvolution, right?
Correct.
Which is, you said, I'm pretty sure one of the number one causes of postpartum hemorrhage.
It's going to be late hemorrhage. So there's early and late hemorrhage. So the number one cause of hemorrhage in the first 24 hours is uterine atony. Okay. And that is like also we call early hemorrhage. Anything that happens after the first 24 hours, up to many weeks after is subinvolution. And the fact that it's not descending is subinvolution. So we have, and then in the chat we have endometritis. So she's got a fever. She has a tender uterus. It's not descending. So, and it's unusually large. So we are thinking subinvolution, and we're thinking that it's caused by endometritis because of her fever and her tender uterus. So the other thing that we could check is going to be her bleeding, number one, because with subinvolution, it can be a late postpartum hemorrhage. Number two, because that we can also see if there's odor in her discharge. Okay, but I am concerned about bleeding for her. So it's a different kind. Early pregnant or early postpartum bleeding with uterine atony is like a lot. It can be a ridiculous amount of blood loss. With late postpartum hemorrhage after the first 24 hours with subinvolution, we can still see blood loss. It can still be a hemorrhage, but it's not usually like profound, minutes matter kind of thing. Does that make sense? I'm still worried about bleeding for this girl, but I do think she has endometritis. Which of the following amounts of blood loss following birth marks the criterion for describing a hemorrhage? Shawnee, I'm going to post the recording. There's almost, okay, so we're almost to the end of the game. And so Shawnee was just saying she has to go. If you're in my, I'm going to send it to the other instructors too, the recording, but in my class, in the announcement that has optional learning sessions, that's where I'm going to stick it. Okay, so you can always go back and see the end later. All right, so for this question, 500 mLs is our criterion for postpartum hemorrhage. If we lose more than 500 mLs, that's considered too much. An assessment for what complication has the highest priority for a client after severe postpartum hemorrhage. Lauren, I was going to ask you who you were after we were done. Okay, so if we are losing volume, and I'm going to tell you guys in OB, the main places that we can have a lot of bleeding that can really trigger DIC is going to be postpartum hemorrhage and placental abruption. So placental abruption we're learning about this week in class, and that's the other time that we really see the kind of blood loss that can trigger DIC. So postpartum hemorrhage and placental abruption, we're really concerned about DIC for this. Two hours postpartum, the nurse obtains mom's temp at 100.1. What's the initial nursing action? Okay, so remember that in the first 24 hours, if we have a temp that's creeping up, it's probably just caused from dehydration from labor. So encouraging fluid intake will be important for her. During the postpartum period, the fundus of the uterus is expected to go down normally about how many centimeters per day? It should be 1 centimeter per day. Methogen is ordered to treat postpartum hemorrhage. Before administration, the priority is to check what? Okay, so we talked about the uterotonics, the medicines that help the uterus contract, right? Do you guys remember what they were?
Methogen, hemabate, oxytocin. I forgot the other one.
That's really good. Does anybody remember the other one? The other one is Cytotec. Okay, or also called misoprostol. Contraindications for Methogen is going to be blood pressure. Okay, Methogen can cause the blood pressure to increase. And so if she is hypertensive, we won't give her Methogen. Also, if she's preeclamptic, we won't give her Methogen. Okay. The other one, Hemabate, has a contraindication also. Does anybody know what that one is?
Is it asthma?
Mm-hmm. It's asthma. Okay. So of our 4 uterotonics, Methogen is contraindicated with hypertension and Hemabate is contraindicated with asthma. All right. And that's the end of our game.
Do you do these weekly?
I haven't been doing them weekly this term because I had in the past and I was not getting anybody that was coming. So I only have a few times that I picked this term that I was doing them. Actually, hold on, let me stop our recording.